This is another one of our videos for crisis intervention, and today, as we begin to talk about the clinical aspects of suicide prevention, that is, clinical situations with individuals in front of us, unfortunately, I'm here to tell you today that it's an impossible task, that basically suicide risk assessment is an impossible task. And we'll go into that, but a lot of it has to do with the idea of false positives and the idea of having a diagnostic test. With the coronavirus these days, we've heard a lot about diagnostic tests and the issues about accuracy. How accurate is a diagnostic test? Are there false positives, that is, people who come up positive on the test but don't have the disease? Are there false negatives, that is, people whose test results are negative but it turns out later they do have the disease? All these same kind of factors come into doing a suicide risk assessment. Another issue about why this is an impossible task is that suicide, fortunately, is a rare behavior. And whenever you have a rare behavior or a rare illness, a rare disease for that matter, something that's rare that has a low base rate in the population that we're looking at, then it's inevitable that whatever we use to test for the presence of that disease or illness or behavior, like suicide, is bound to over-identify, is bound to identify many people who actually will not go on to attempt suicide or complete suicide, and these are false positives. But first, let me show you an interesting piece of research that just came out a few years ago. This study by Franklin and a bunch of other authors did a meta-analysis, which is a way of combining many other studies of attempting to predict suicide. And you can see that the title, Risk Factors for Suicidal Thoughts and Behavior, meta-analysis of 50 years of research. And they looked at 365 studies. I'm sure they looked at more than that, and many of them were excluded because of poor methodology. But they did find 365 articles that were adequate or better methodology going back as much as 50 years. And the sobering conclusion when they looked at all these studies was that our best scientific knowledge predicts suicide, and that's any of these three: suicide ideation, suicide attempts, or suicide completions. It predicts it only a little better than chance. So, when you have a client in front of you and you're doing a risk assessment, you're wondering if they're high, moderate, or low risk, you could flip a coin and you wouldn't be too far off, according to this summary of all of these studies over the years. Now this last bullet point here identifies one thing that I need to mention, and I'm not sure I have so far, and that is, in studying suicide, we have to be very clear about what we're talking about, because many studies focus on suicide ideation, many other studies focus on suicide attempts, and finally, still other studies focus on suicide completion. And those are three different populations. For example, one simple way to remember that is that suicide completions are something like 78% men in the United States, whereas suicide attempts are something like 80% women in the United States. So obviously these are different populations we're looking at. And if we're really focused on stopping people from dying of suicide, then it's not really clear how helpful it would be to study suicide ideation or suicide attempts. In this meta-analysis, they looked at all three separately, which of course would be the appropriate way to go. And here's some examples of some of the findings. What variables in the respondents' past best predicted current suicide ideation? And these numbers listed here are odds ratios. Odds ratio means what are the odds? Well, let me take the top one. In order to understand and predict from a group of people which ones have suicide ideation in the present, we would look back at their past history and administer some questionnaires, and it turns out, no big surprise, that the people who had prior suicide ideation were about 3.5 times more likely to have current suicide ideation than people who did not have prior suicide ideation. Okay, you understand? So in other words, in predicting suicide ideation, people who have hopelessness are 3.25 times more likely to have suicide ideation than people who are not hopeless. People with a diagnosis of depression are 2.5 times more likely to have suicide ideation than people who don't have depression. Now, that these may sound, and these are statistically significant, and you may say, well, that sounds pretty good, except that when you think actually about how few people die of suicide, the fact that, for example, depression is 2.5 times more present in ideation than people who don't have ideation doesn't help us all that much, you know. It's similar true for suicide attempts, and similarly true for suicide death. So in predicting death, we see that prior psychiatric hospitalization, 3.5 times more likely in people who die of suicide as compared to people who don't die of suicide. However, think of how few people in the country, 47,000, die of suicide, and how many people have been psychiatrically hospitalized in their lifetime. And I guarantee you it's many more than 47,000. So if we use psychiatric hospitalization as our test, remember, ideally here we're looking at a test, like a diagnostic test, that will predict whether the person has the disease, in this case the disease being dying of suicide. And if we look at the population as a whole, there's many, many more people with prior psychiatric hospitalization who will not go on and who have not gone on to kill themselves. So using that marker is not going to be very effective. I'm going to go more into this in a minute, but as a summary along the way here, I want to just point out that suicide risk assessment is a difficult necessity. We need to do it, we meaning social workers on the one hand, or mental health professionals in the larger category. This is what society expects of us. This is what people expect of us. And even though scientifically it's very, very difficult, virtually impossible, this is a task that we're given and we have to do the best we can. When we talk about risk assessment, we're talking about probability, not prediction. And that's a direct result of what we've just begun to talk about, that prediction is so fraught with difficulties and so inaccurate that instead of saying, yes, this person is going to die of suicide in the next 48 hours, the best we can do is say high, moderate, or low risk. And even then, we're not going to be very accurate, but we're going to, try as best we can to say that we think this person is at high risk, for example, to try to kill himself or herself in the next few hours or the next few days. It's a probability. It's kind of like a weather forecast, right? It's 70% chance of rain. And we do that by knowing the client's history and asking a series of questions about information we don't know, about risk factors and protective factors, which, as I've said before, is kind of like balance scales. So we're investigating risk factors, which makes it more likely for someone to die of suicide, protective factors, which makes it less likely, and it's in the context of the individual. What do you know about that person at this point in their life? It's a clinical judgment, and that means there isn't any way around it by having some kind of checklist or rating form or some. I'm just telling you, obviously, from the research we just looked at, that the science is hardly better than chance. So there isn't any form or rating scale, and we'll look at a few of those in the future and critique them. But there isn't any rating scale, any scientific instrument that you can add up the points and that will tell you whether or not this person is going to die of suicide, or even whether they're high, moderate, or low risk. It doesn't exist. In the end result, it's always a clinical judgment. And that doesn't mean you can't use a rating scale or a list of questions or any kind of material you want when you interview a client to remember what questions to ask, what areas to look into. But there isn't any way to fill out a form, add up the points, and come out with a judgment that way. It's a clinical judgment. Another aspect of suicide risk that makes it very difficult to pin down is the fact that it's very fluid. It waxes and wanes. People can go from being highly suicidal in the morning to not very suicidal in the afternoon. which adds a whole other layer of complexity, which actually in some ways maybe is similar to the coronavirus also, because we joke around now, it's fine to go get a test for COVID, and that will tell you you don't have it today. But a week from now, what good is that, right? Who knows who you've been exposed to? Who knows who might have been an asymptomatic carrier? So the risk of COVID varies in a different way, but varies depending on your circumstance. And the risk of suicide for people who are thinking about suicide waxes and wanes and varies a lot, even in the course of a day. As I said, there's no objective rating scales, and typically the best we can hope for is to come up with a fairly competent assessment that rates a person as low, moderate, or high risk. So let me go further now and talk about the false positive problem again. And I'll come back to this other assessment variable, I guess. I'm not sure I would call it. Low positive or positive predictive value, and a large number of false positives is the same as having low positive predictive value. Positive predictive value means what's the probability that the person in front of you who scores positively on the test, in other words, they have the coronavirus test and it says yes, you have it, or in our case, suppose we use suicide ideation as our test, and we ask people if they're thinking about suicide or not, and then we wait around and see what happens to all the people that we have interviewed, and especially all the ones that said they did have suicide ideation. And it turns out that of the people who have suicide ideation, very few of them go on to kill themselves. So the positive predictive value means what's the probability if someone has a positive test that they actually do have the disease, in this case completed suicide. And it's if we use suicide ideation, it's very low. In other words, there's many false positives. Many people will acknowledge that they have suicide ideation and will not go on to kill themselves. And just to illustrate that, in 2017, according to SAMHSA, which, as you know, the Substance Abuse and Mental Health Service Administration of the federal government, the U.S. population is around 320 million. In 2017, about 10,700,000 people said in a survey that they had seriously considered suicide. Of those people, about 1,400,000 actually made an attempt, and of those people, about 47,000 completed suicide. So you can see we start out with 10 million to get down to 47,000. Okay, so if we use suicide ideation as the predictive test, the probability of a positive test actually correctly identify those who will go on to die of suicide is less than 1%. 0.4%. So that's over, you'd have to interview over 200 people to find one who would go on to kill themselves. And this is the concept of positive predictive value. You might guess, probably correctly by the way, that negative predictive value means what's the probability if a person scores negative on the test, whether it's for the coronavirus or negative, they do not have suicide ideation, what's the probability that they will then not have the disease, either coronavirus, or they will not have our disease that we're talking about here, suicide? Negative predictive value. And we'll come back to that also. So here's our illustration. And for those of you who did listen to the professor's welcome, I gave you some background on my previous work and work especially at the Psychiatric Emergency Services at the University of Michigan Hospital. So living in Ann Arbor, it's easy to think, okay, we're talking, as you recall, rates of suicide that are per 100,000 people per year. So here's Michigan Stadium with 100,000 people in it. And here's what we're going to do to illustrate the false positive problem. On one Saturday afternoon when it was a football game, this is obviously pre-COVID days or post-COVID days, and we're all hoping that we'll be there by the fall of 2021, that we're going to assess all 100,000 people in Michigan Stadium. We'll pass out a questionnaire, we'll require them to fill it out, and we'll collect it at the end of the game. we'll wait a year, and by looking through the Michigan Death Registry and also combined death registries from other nearby states, remember the rate of suicide most recently is about 14.8 per 100,000 per year. So let's round it up to 15. So out of these 100,000 people, probably about 15 in the coming year, in the subsequent year, would have killed themselves. And so we get those names from the death registries, and we go through then with our 100,000 questionnaires, and we separate them into a pile of the 15, that is the 15 people who killed themselves. And then in our other pile, we have the people who did not kill themselves, 99,985. And once we've identified those who die by suicide and those who don't, let's pick a variable we're going to look at to try to differentiate between the two. And let's say we decide on hopelessness. And now the numbers I'm about to give you are made up, but the statistics are accurate, and well, you'll see what I mean in a minute. It would be very common. Hopelessness is certainly a risk factor for suicide. So in my made-up results, that this is probably close to what we would get if we actually did this experiment in reality, that of the 15 people who killed themselves, 85% of them had high levels of hopelessness. And there's a variety of ways to measure hopelessness. We won't go into that now. And then in the other pile of football fans who did not kill themselves, the levels of the number of people with high levels of hopelessness is only 15%. So we'll do the statistics and find that the difference between 85% and 15% is highly statistically significant. Okay, so that means now we have this another test. In this case, the variable that we're going to use for our test, once again, similar to a test for a disease, our test is high levels of hopelessness. Because we found that the vast majority of people who kill themselves have high levels of hopelessness, and the vast majority of people who don't kill themselves do not have high levels of hopelessness, right? So this seems like it would be a good way to go. So we go back out to another group of 100,000 people. Here we go. This is our second group of 100,000 people. And in this case, we, again, require them to fill out a questionnaire. Only this time we require them to fill it out by halftime. And then during the second half of the game, we have a supercomputer and many technicians that we analyze all 100,000 questionnaires by the end of the football game. So now we've identified the people that we need to do something with, we've identified the people that are at high risk for killing themselves over the subsequent year. So what will we find? What are our results? Well, kind of sobering. We will capture probably roughly 13 of the probable 15 people who would die of suicide in the subsequent year. And of course the question is then, what do we do about it? Do we involuntarily hospitalize them? And remember, it's 15 per 100,000 per year. So do we involuntarily hospitalize them for a year? If we did, we could probably prevent their suicides. Obviously, that's highly unrealistic. But even more significant in terms of our ability to conduct valid and accurate risk assessment is we also would wind up with 14,987 false positives. Okay, so you visualize that. We have our police department, and as the 100,000 people, I guess we require all the football fans to wear a big ID. And we have analyzed all the questionnaires at halftime and issued to the police a list of all the people who had high levels of hopelessness. And how many would that be? Well, remember, 15%. 15% of everybody had high levels of hopelessness. Somewhere, and you see this right here in this slide, somewhere hidden in our 15,000 people are let's say 13 or so of the people who would die by suicide, but the rest of that group is 14,987 people who will not kill themselves. We just don't know in that big group of 15,000 people which are our 13. There's no way to know. So this is, I think, a simplified example of the problem with false positives when there's a rare outcome. Huge numbers of false positives. So you might say, well, we need more variables, right? Just rating hopelessness is not enough. Can we do better than that? And as far as I know, there's only been one real experiment. It's not really an experiment, but it's an after-the-fact experiment to try to do exactly this, multiple variables. There's tons of studies. Well, we saw back in the beginning, right, that the Franklin article looked at 365 studies. But to my knowledge, most of them did not look at multiple variables over a long period of time. However, Alex Pokorny, a psychiatrist that worked at the VA, did this in the 70s and 80s. And he kept track with fairly detailed questionnaires of 4,641 people who had been psychiatric inpatients and followed them for at least 4 to 6 years afterwards. They were mostly male, 98% male, because it was the VA hospital. And out of those 4,600 former inpatients over the course of 4 to 6 years, there were 63 completed suicides. So, excuse me, right away, here's another illustration of the rareness, the rare outcome of suicide. Because even in a group, much less not the general population, but even in a group of psychiatric inpatients, still only 63 out of 4,600 actually died by suicide over those coming years. Now that, if you do the math, that turns out to be something like 271 per 100,000 per year. So you can see it's 20 times higher than the regular population. So definitely an elevated rate, but still a rare outcome. Then Pokorny went back and looked at all the different variables that he had gathered and all the questionnaires that people had done, and found that there were 4 variables that best distinguished between the suicides and the controls. Controls meaning the people who did not die of suicide. So in our example now, this is the test. So the test that best predicted had 4 items on it. Whether the client had previously made a suicide attempt, whether they had a diagnosis of either a mood disorder or schizophrenia, whether they were single, widowed, or divorced. And I think the idea here is people who did not have a close, intimate partner. And then 4th, previously on any VA suicide list. That is, many of these people had been hospitalized before and had been identified before as being potentially suicidal. Okay, so those 4 variables. And then he took those and went back and reapplied them to the same group to see how good his test would be. And the findings were, using that test made up of those 4 variables, that they were able to correctly identify, correctly predict 35 out of the 63 people who actually did kill themselves. So that's 56%. Okay. The 28 people then would be considered false negatives. That is, remember, the test correctly identified 35 out of the 63 people who died, but it was wrong, meaning it said that they would not die of suicide. So that's a false negative out of those. And on the other hand, it also falsely said that another 1,206 people would die of suicide. So once again, we have correctly identified 35 people and then found that they're somewhere mixed up in a group of another 1,200 people. And so even with 4 variables, very limited ability to really home in on who are the people that are actually going to die of suicide. So sensitivity is for a test, like a test for the coronavirus. Sensitivity and specificity are measures of the test, not of an individual, measures of the test as a whole. So if you were planning a suicide prediction study, you would want to look at sensitivity and specificity of your test. If you were planning to administer the coronavirus test, you want to know about sensitivity and specificity. Sensitivity of a test is a proportion of people who score positive on the test who actually have the disease. Okay, maybe I said that backwards. Proportion of people who actually have the disease who score positively on the test. Okay, proportion of people who actually have the disease who score positive. Doesn't tell you about any individual. And a good test would be 100% sensitive. That is, it would identify everybody, that everybody who scored positive actually has the disease. Specificity is the proportion of people who don't have the disease that score negative on the test. And ideally, that would be 100% also, but of course, it never works that way. All right, so in this case, the specificity was 74%. And then, if you're a clinician, though, working with an individual, you don't really care, directly about that, about the test, how accurate the test is. What you want to know is if the client in front of me scores positive on my test, then what's the probability that they're going to go on and actually die, in this case, actually die of suicide. So we know in the Pokorny example, if you had someone sitting in front of you, that the positive predictive value, unfortunately, is only 2.8%. So someone sitting in front of you scored positive on those 4 variables that we talked about a minute ago. What's the probability that that person is actually going to go on to die of suicide? Only 2.8%. Negative predictive value, if the client scores negative on the test, what's the probability that they in fact won't kill themselves? And in this case, 99%. If they score negative, 99% probability they won't do it. So that's given rise actually to some jokes about suicide prevention, and that is that the most accurate thing would be to always predict no suicide, and you would be correct 99.9% of the time. Okay, so you can see why the idea of doing a risk assessment is very difficult. In fact, I think, as I called it in the beginning, it's an impossible task. It leaves us with this final thought, I would say. So if simply looking at suicide ideation is extremely inaccurate in predicting who will die of suicide, and 4 variables was pretty inaccurate, but a little bit better, if we ask questions and look at 20 or 25 issues or variables or characteristics, can we make a better prediction? We're hoping that that's true, but we don't really know that. Conducting a scientific study with 20 or 25 different variables, all of which have different, male, female, suicide ideation or not, suicide attempt or not, how many previous attempts, blah, blah, blah. When you start multiplying the variables, pretty soon you need a huge group, a huge sample size, in order to have enough variability within each of the variables. So it becomes like an impossible task. In a clinical situation, we're trying to be as accurate as we can by looking at as many variables as it's practical. There's a limit on how much you can do in one interview, but we're hoping we can be a little more accurate by looking at a wider range of characteristics. Okay, so now that I've set out the pessimistic case of what we have to do, nonetheless, we're going to be spending a lot of time talking about how to do the best possible risk assessment that we can do. Okay, and I'll see you in the next video when we'll begin to talk more about that.